So my name is Victoria Salgado. I am the program coordinator for the IHCI team at Mental Health America of Greater Houston. I'll let my colleagues introduce themselves.
Hello, everyone. My name is Sujina Peter-Julie. I am the lead program specialist for our Integrated Healthcare Initiative program here at Mental Health America of Greater Houston. It's nice to see you all today. Thanks so much for joining.
Hi, everyone. My name is Alina Jacob. I'm a program specialist with Integrated Healthcare Initiative, and I'm so excited to see you all.
So for those who are not familiar with our organization, Mental Health America of Greater Houston is driven to community solutions to promote mental health for all. And we do this by using education, advocacy, and collaboration to drive systems change. And the purpose of the Integrated Healthcare Initiative specifically is to create partnerships, provide leadership and vision, advocate and educate, and provide technical assistance to implement and sustain efforts that promote integrated care. So ultimately, our vision is for integrated healthcare to be accessible, cost-effective, and the standard delivery of care for all. So for today, what we hope you get out of this training is to identify the key components of the PCBH model, identify the team members essential for this model, and understand the role of each team member in the model. So we do want to ask you all, what is your role currently in your organization? If you can type it into the chat box, please. We got admin, finance, clinician administrator, director of operations, psychologist, clinician, value-based contracting. So we got a lot of variation, which is really great. And we hope that it makes for good conversation because we will have a breakout activity at the end, and we do hope that you stay engaged. Moving on to the next poll. Where is your organization in the process of integration? Are you learning and exploring? Are you beginning to implement, or are you already fully implemented? Doing quality improvement? If you can also type that into the chat. Beginning, co-located care, learning and exploring, advanced full implementation, quality improvement. Awesome. So again, we have all different varieties here. Thank you all for typing it in. I'm gonna go ahead and pass it on to my colleague who's gonna get you all started.
All right. Thank you, Victoria. All right, so welcome everyone. For those of you who just joined, make sure to change your name on Zoom so that it's helpful for Victoria to take attendance. So we're going to get started with a really quick and brief refresher for integrated behavioral health. So for those of you who didn't join us in our previous trainings, we wanted to tell you a little bit about what integrated behavioral health is. So for those of you who are just exploring and seeing what it is, I think this will be really helpful. And for everyone else who's already implemented or doing ongoing quality improvement, this will be a refresher for you all. So starting with what is integrated behavioral health? I think it's so important for us to start off with the definition of integrated behavioral health, because today we're going to talk about one of the models, and in order for you to understand the models, you have to understand the umbrella that it falls under, right? So that is integrated behavioral health. And according to the Agency for Healthcare Research and Quality, integrated behavioral health is the care that results from a practice team of primary care and behavioral health clinicians working together with patients and families using a systemic and cost-effective approach to provide patient-centered care of a defined population. So this team addresses mental health, substance use, and behaviors that affect physical health, which are identified during primary care visits. So next, we are going to be covering the key elements of IBH, or exactly what is IBH made of, right? So with that said, it doesn't matter whether today you're learning about the PCBH model or you may be interested in learning about the COCM model. No matter the model, these key elements are what makes up the IBH for you to successfully implement this in your clinic. So the first thing is that both these models should exhibit patient-centered, team-based care. And that in itself is very collaborative, right? So the IBH, you have a PCP and a mental health or behavioral health provider working together to provide a patient-centered care where they both have access to the patient information and they're both contributing to treatment plans. Within IBH, it's also a population-based care where the team or clinic again decides on targeting one population in the clinic, which is like, if let's say your clinic wants to focus on just your anxiety patients or just your depression patients, you'll be targeting just that one population, ideally to improve your overall clinical outcomes. Then it should be a measurement-based treatment to target care, which is where treatment plans should be actively changed until you meet your clinical goals. Then it is utilizing evidence-based care, such as brief interventions or psychotherapies, motivational interviews, and etc., to engage the patients in their own treatment plan, kind of seeing what works for them, making it as personalized as possible for the patient, considering what they're dealing with. And then finally, we want to make sure that IBH is that our patients really experience that one-stop shop when they're being part of this type of service delivery, right? So when they're going to their PCP, we want to make sure the patients feel supported and assisted in both their mental health diagnosis or mental health issues or behavioral health issues, as well as their physical health concerns. So we talked a little bit about what IBH is, or what integrated healthcare is. So let's talk about what it's not. So because this is still a very new and complex idea, there's a lot of conceptions on what it could be, right? Starting with the fact that if your clinic is providing co-located physical health and behavioral health services in the same building or clinic, then that's not IBH. So you might be wondering, like, okay, what's co-located care, right? So it means that you as a primary care provider might have a behavioral health provider somewhere near your clinic. Again, it can be the same building, a different floor in the same clinic, but you have absolutely no relationship or partnership with that provider where you have access to the same shared patient information. So you're just two different entities working in the same building. However, you're not communicating with each other. You're not collaborating with each other, where you share patient status or patient progress. And exactly, that is what it is, right? It's co-located care. That's not integrated care. That's two separate entities working in the same building. So that does not mean you are a fully integrated organization. So in order to deliver proper integrated care, you need to have behavioral health services integrated in the same clinic, in the same room, so that they can work collaboratively and as a team. So IBH is also not integrated if you consolidate separate funding for physical health and behavioral health care. So just because you have separate funding for both these types of care doesn't mean that your system is fully integrated or you're fully practicing integrated behavioral health. And it's not about putting physical health and behavioral health services under the same lines of authority. So integrated care is not just a one-person job. In fact, it's an organizational effort to ensure that your services are fully integrated and you ultimately attain all of the key elements that we talked about within your organization. And lastly, just because you have a contract with a managed care organization or MCO to manage both the physical health and behavioral health services does not mean that your system is fully integrated. So none of these listed bullets is sufficient enough to provide integrated care. There's just so much that goes into this. But lucky for you, all of you guys that are attending our current presentation and also our next presentation in a couple of weeks will really help you to learn more about how to get started and explore the different types of models that can fit your organizations and meet the needs of your organization. And the next slide is going to talk about the two widely adapted models of IBH. So again, today you're here and we're going to focus on the left side of the Venn diagram, which is the primary care behavioral health or PCBH model. And I think it's kind of important to establish a good understanding on the differences between both of these types of models. So first thing being that the primary care or the PCBH model has a behavioral health consultant who is part of the team. And a PCBH model also utilizes a warm handoff to the BHC. This is where the PCP will engage the BHC through a warm handoff where they brief, and we'll talk more about it later in the presentation, but just for a brief understanding, it is to engage them and bring the BHC into the patient examination room. Then a PCBH model also utilizes an evidence-based behavioral treatments customized for primary care. And the biggest difference between the PCBH and the COCM model is that it is more short-term treatment, which is like less than 6 sessions. But as for the COCM model, instead of a behavioral health consultant, you have a behavioral health care manager that's part of the team. And most of the time, a clinic that takes on the COCM models, they deal with a lot more complex behavioral health conditions and needs. So they are provided support by a practitioner or a nurse practitioner or a psychiatric consultant. And a COCM model, also different to the PCBH model, uses the registry for patient tracking, follow-ups, and monitorings. And because, again, for the likelihood of complex cases, they utilize a patient registry for long-term treatment, which can range anywhere from 3 to 12 months. And as for the similarities, I think Venn diagrams does a really good job of showing you what they have in common. And it is that both these models, they assist in saving expenses, or they help you save costs, right? So for each organization, it's kind of different when it comes to this aspect of it. You might be a clinic where you are overspending. And once you adopt integrated behavioral health, it might help you reduce some costs. Or you might be a clinic where you're underutilizing your funds, or you're not spending as much as you need to. So this is where you might have to spend a little bit more to fully integrate your clinic. Another thing that's common with them is that they're both team-based care. They both have a PCP, their staff, as well as a behavioral health provider or consultant or a behavioral health care manager working on staff. And they both utilize evidence-based screenings with diagnosis to provide integrated services. And the next slide is I'm gonna pass it on. Oops, sorry. Okay, next slide, I'm just gonna pass it on to Sajina so that she can provide you with a really cool activity and talk to you about what PCBH model is.
Thanks, Alina. So before we get started and really talk about what PCBH is and do a deeper dive, I actually want to start us off by asking you and finding out what your understanding of PCBH is. But there's a trick to this. You have to define what PCBH is in one word, and I'll explain what that is going to be like in a second. So I don't know why it starts right away. Okay, so what I need you to do is on your computer or on your phone, I want you to go to this website that is highlighted on the screen, classpoint.app. And once you go to that app, I want you to enter, it's going to ask you to enter a code, which is listed right up here, 80464. type in that code and you'll be able to get into this activity. And once you get in, I want you to type in 3 words that describes PCBH for you. What does PCBH look like to you? Describe that in 3 words, enter those, and I'm gonna start the game now. And I'm gonna give you guys about a minute or 2 to get this done. We're starting to see some responses. Collaborative, integrated, patient-centered, team-based care. I mean, that's perfect 3 words, team-based care. Keep them coming. Whole patient, quality, collaborative, partnership, collaborative, integrated, accessible, primary care driven. That's a good one. Solution focused. That's a good one too. Holistic. I really like that holistic approach. Patient-centered. Partnership. Best ever. That's a good one. Okay, about maybe 10 more seconds and then I'll stop. Okay, beautiful. Thank you all so much for doing this. What's happening? Okay, so I'm just gonna put this up here and allow you guys to just look through this and see some of the commonalities. I see that collaborative, the word collaborative is used at least 3 times, if not more. And it's just really good to see that you have somewhat of an understanding of what PCBH model is, but let's go ahead and talk more in detail about what it is. So the PCBH model, the goal of this model is to improve the primary care team's ability to manage and treat behavioral health, mental health, and physical health conditions of the patients that are common in the primary care setting. For example, depression, anxiety, substance use, pain, obesity, and so on. So this model, it focuses on the entire clinic population. So it's not just client-based. It does not target the health of an individual, but rather focuses on the overall health and wellness of the broader population. This model has the behavioral health consultant as part of their team. They're counted a core member of the primary care team. And the behavioral health consultant can either be a psychologist or a licensed social worker, LPC, LMFTs. And together they operate with the primary care team from the same clinic, same workspace, and they share equal responsibility of providing quality care to their patients. But as I'm talking about PCBH, there are also some misconceptions that some people think it's a separate service or that it's a specialist kind of care. So I just wanted to show you the differences between the PCBH model versus the specialty mental health care. So when we talk about the team-based care in the PCBH model, it's more than just the co-location of the primary care behavioral health provider. The model of care for PCBH is that here, the behavioral health provider, they focus on the overall health. So it's a of the general population. So it's a population-based care, whereas a patient, when they go to visit a mental health specialist, the mental health specialist, they focus on each patient's need. So it's more of a client-based, more of a patient-based care. The main goal of PCBH is to improve providers' ability to address behavioral health and mental health, physical health conditions, support small patient change efforts. Remember, PCBH, it's supposed to be a short-term care. So they address acute health conditions and prevent them from becoming chronic, which can also result in medical cost saving. And at the specialty mental health, the sole purpose is to really work with patients long-term to resolve patients' mental health issues. They provide long-term care and treatment where they meet with the patients until they are fully recovered. And then, of course, the team structure is going to be different as well. In PCBH, the primary care provider, they oversee the patient, they work with the behavioral health consultant and receive their feedback and their recommendation for patients' treatment plan. They are also the ones to prescribe medication as needed or prescribe or provide referrals to mental health specialists if needed. And on the specialty mental health, it's the therapist and the primary care provider who referred the patient to the therapist. Now they are going to oversee the care of that patient together. In PCBH, the behavioral health provider, they are counted a member of the primary care team, right? Whereas in mental health specialists, they are considered more of a specialized service. This is where you would go with referrals, and the specialists are not the part of the primary care, rather they are part of their own specialty mental health team. And then the cost aspect is going to be very different as well, because primary PCBH is going to be a part of the primary care service. The cost is going to be very different compared to if you were to go to a mental health specialist. It's going to vary depending on each patient's mental health condition and each patient's cases. So those are the differences between the model and the specialty care. So now that I've talked about what is PCBH, let's go over what PCBH is not. So it's not just an added program, pilot program, separate service. It's not supposed to be any of that. It's supposed to be a very much integrated service that is provided in a primary care setting. PCBH is also not a long-term care either. The follow-up sessions with the behavioral health consultants for patients that can last between 1 to 6 sessions. And so it's also not a short-term care. It does focus on long-term prevention, but it's definitely not a long-term care. The behavioral health provider in PCBH, they are also not there to just conduct all screenings. You actually don't need behavioral health providers to conduct screenings. Your nurses, your medical assistants, even the primary care providers, they all should be able to conduct these screenings. You don't need behavioral health provider to do that. They're also not there just to address mental health conditions. Your behavioral health consultants, they should be competent enough to address the wide range of health conditions that are common in the primary care setting. So you need to utilize them for, all three, the mental, physical, and behavioral health conditions that are common at the clinic. And they're also not there just to address any crisis that occurs in the clinic, any emergencies. Again, it's supposed to be a collaborative team effort to work together to provide that patient-centered care to the patient. So the behavioral health provider should not be treated as just a separate service focused on mental health services.
Is it that you don't feel like living because of your pain and you're not being able to get relief?
Okay. So this is a really good video that was put together by the American Psychology Association. They do a really good job of talking about, the impact of having behavioral health services in a primary care setting. So I'm just going to play that for you all. It's a very short video, should not take very long.
Behavioral health services is such a critical part of overall health. Within
family medicine, a large percentage of patients come in with medical problems that put them at risk for behavioral diagnosis like depression.
Depression is the #1 complication of childbirth.
The numbers of children that have unmet behavioral and developmental needs is staggering.
We know there's an unmet need in our community. Let's go ahead and address it.
There's a lot of energy around integrated care, and I think there's a lot of good reasons to believe that sort of reconnecting the mind and the body and caring for them as one is going to lead to better outcomes.
It offers way more seamless service. It gives me an opportunity to always have the physicians in the office. We can consult, they know the families, I know the families, and we come together and we just provide a much better service to the families.
I mean, I love practicing this way because I have the doctors as a resource.
The longer we work together, the more expert we each get at what the other one does.
In terms of having their medical record, you have so much more context and you have a team to work with.
So what it's allowed me to do is see patients more efficiently and see them more effectively.
We're able to reduce a lot of barriers to care.
You can't tell looking at our patients in the waiting room who's here to see whom. So I think the stigma goes completely away. It's a godsend.
We really have an opportunity for constant collaboration, feeling like we're really a true member of the medical team.
There's that capacity that gets built and that comfort level that comes from practicing together.
We raise each other's skill set.
We need psychologists in private practice. We need psychologists working in mental health clinics to be able to care for our patients, but we also need psychologists in primary care settings.
It's a great model. I can't think of doing psychology outside of the model that we do it here in an integrated care model.
I could not imagine nor want to practice in any other way.
This is just good preventive health. It's good health care. Most importantly, it's what we ought to be doing.
You know, it takes a village to raise children. Well, they're part of my village.
I hope that video was informative for you. I really like this video. I think it just does a really good job of summarizing in a nutshell the impact of having a behavioral health provider in a primary care setting or in different setting. So I'm talking a lot in theory about why PCBH, right? Why we should do it, but there's also some studies that have been done in this model. PCBH is an evidence-based approach. There are studies that have been done that has proven PCBH to help mitigate burnout in primary care providers. It has proven to have highest retention and satisfaction among patients who received PCBH services. It's also proven that it increases engagement and linkage to the specialty mental health treatment when needed. It also has proven to improve access to mental health care, proven to reduce suicidal ideation after visiting a behavioral health consultant. Also has large reduction in specialty mental health referral rates, reduces mental health care cost, decreases rates of preventable inpatient utilization significantly, and also reducing emergency department encounters. So it definitely has its benefits and has proven to work really well. So I just wanted to put out some examples out there that shows that, you know, this can definitely be done. So these are the keywords that truly describe PCBH model. I asked you to do something similar at the beginning of the session, but this is basically it. It includes all of the components that are necessary for the model, such as it takes place in a primary care setting. It includes a primary care provider and a licensed behavioral health provider consultant. And they're also known as generalists in this model because they're educating the primary care provider about the behavioral health. They're educating patients on behavioral health. They're working as a team to create a treatment plan for the patients and are able to provide quality care to patients. The behavioral health consultant in this model, they can be a combination of, they can be a psychologist, LPC, LMFT, LCSW. They operate from the same office location, sharing same space with your other staff, like your medical assistants, your nurses, the physicians, so that they're available for on-demand warm handoffs and are able to take over the patients immediately, conduct brief interventions with the patients, which can last from 20 to 30 minutes. And that's where they provide evidence-based care and focus on functional improvements. So that is PCBH in a nutshell. Next, I'm going to pass it over to Alina to talk about the key components of this model.
Thank you. All right, so we had a key components section for IBH, and now we're going to move on to the key components of PCBH. Okay, so sorry, my slides were lagging over there a little bit. So the key components for PCBH, they overlap with the key components of IBH. The only difference is that now it's more population-based and it utilizes evidence-based treatments, as Sujina mentioned earlier, and they utilize the PCBH model utilizes brief interventions between their PCP and their behavioral health consultant. And in the next couple of slides, I'm going to talk a little bit more in detail about each of these components than just list them out for you. So the first component, it was population-based approach, right? So what does that mean? It means that it does not just target the health of individuals, although that is still very important. The clinics or the organization, they look at the overall clinic population and how the clinic is doing in terms of their clinical outcomes, right? So it's kind of like, say your 70% of your patients are struggling with anxiety or depression. You want to be able to do everything you can to kind of bring that number down if that's what you target, right? And so being population-based also means that it identifies and addresses a wide array of behavioral health needs. And this can include diabetes, anxiety, depression, obesity, and more. And I think the biggest thing to kind of pay attention to is that a PCBH model, when it's population-based, it gives an early opportunity to identify and provide prevention and behavioral interventions, which kind of keeps your clinic population from progressing from acute problems to chronic issues. So it can be easily mitigated. The whole point is early identification and quick resolution. And I think when you guys were playing the cloud, someone responded in that way too. And I think that's very important. And lastly, like the PCBH model, it is long-term prevention because you engage your patients with prevention activities. And this is done through regular consultation with the PCP or the BHC, co-monitoring of patient response, having follow-ups, and even changing treatment plans as needed to meet the target clinic goal and patient goal. And let's say even after all your attempts, let's say you've met with the patient for 3 to 4 to 6 sessions and they're still not improving, then you can also adjust the treatment plan to where you can refer them to an actual specialist, which can be outside of your clinic. So in a nutshell, this model focuses on the overall health and wellness of your clinic population and your targeted population within your clinic. And an example of this could be, again, like coming back to 70% of your patients that might have anxiety or depression, and you'd want to target or have a goal where you want to bring down that 70% to 60 or 65 or whatever that is feasible for you, so that you can provide your patients with a proper treatment plan, trying to improve their conditions for those of them that are already struggling with depression. And for the rest of the population, you can try to prevent it, right? So you'll be paying extra attention to all your patients who may be struggling. And this is where you'll be working with your BHC to provide those prevention activities and those evidence-based treatments and psychotherapies to follow up with the patients and really just keep them from getting worse. And the next component is what are the evidence-based treatments, right? So how does the PCBH model utilize evidence-based treatments? So how does that help with treatment? So this is, again, as it says in the title, it's evidence-based. So there are many evidence-based interventions that are proven to be effective in primary care clinic and its population. And a few of them are actually the problem-solving therapy. I don't know how many of you guys are behavioral health provider here, but problem-solving therapy, also known as PST-PC. I don't know if that's the right way of saying it, but this is the most widely used intervention to treat depression and anxiety in the primary care environment. So what it is basically it's a brief therapy that uses about 6 to 10 30-minute sessions to help patients solve the here and now problems that are contributing to their depression. Then we have brief cognitive behavioral therapy, also known as CBT, which is also a beneficial therapy or intervention for depression and anxiety in primary care. This is where CBT uses short-term goal-oriented therapy to interrupt patterns of thinking that prevent the patients from feeling better. So this type of intervention allows it to be a little bit more accessible in primary care because they use short and fewer sessions, or there's a need for shorter and fewer sessions. The next one is interpersonal counseling, also IPC, and this focuses on the current functioning, recent life changes or stresses and difficulties in interpersonal relationships to treat depression in primary care. And then we have behavioral activation, and this is entirely based on behaviorism. So this intervention, it assists patients who have stopped overall like engaging with work, their social life, with like caring for their health, or even participating in their family activities because of their mood. And so this action plan, it includes reducing avoidance behaviors by identifying any obstacles or triggers or consequences that the patient may be afraid of or just going through. And lastly, we have motivational interviewing, which is a structured counseling session that has been shown to be one of the most effective in motivating patients to change addictive behavioral issues. So it's a collaborative guiding method that is patient-centered, so that it can elicit and strengthen the motivation to change among the patients. Let's say they're dealing with a smoking addiction or something else. This is known to help them the most. It's a 30-minute long counseling session. So the next key component was the brief intervention. So what exactly is the brief intervention within the PCBH model? So brief interventions are an integral part of the PCBH model. So we've been saying it so much throughout this presentation. I just feel like we're being repetitive, but at the same time, just to be a little bit more clear, these are, again, those quick 16 to 30 minutes of consultation with the BHC immediately following a PCP appointment. And I feel like that can be misconstrued. So for all of you guys that are new and exploring, you're having an appointment with a patient, and the PCP comes in, does their part, and then they step out, and then the BHC would immediately come into the room. And so when the PCP steps out, the BHC is already outside of the room, and they're debriefing on the patient, like, hey, this patient recently had a family member that died. This is what's going on with them. Do you think you can help? And then the PCP obviously asks the patient if they're willing to see a behavioral health consultant. And then they come in and they use those evidence-based interventions that we just covered in the previous slides to talk to the patient in those really quick 15 to 30 minutes gap that they have. And so this is considered short-term care because they will only be 1 to 4 follow-up sessions after the initial visit. So they use guided conversations to build a good rapport with the patients, which allow them to share ongoing communication about treatment plans and how they are responding to it. The next one, I think those are all of the key components for PCBH. And now we're going to move into talking about the roles of the different team members. So I'll let Sajina go over the different team members and their roles.
Thanks, Alina. So let's talk about the team members that are essential for the PCBH model. And that includes the following. It includes the leadership, patients and families, primary care providers, behavioral health consultant, nurses and medical assistants, as well as your front office staff. So if you have all these team members in your primary care setting, then this can definitely contribute to a successful implementation of the PCBH model. And I'm going to talk about each of their role in this model. Let's start with the leadership. So when you hear the word leadership, I'm not implying just the directors and the managers of the clinic. It has to start from the top. And when I say that, I'm talking about the C-suites, your CEOs, CFOs, CMOs, COOs, and so on. And their involvement in this is going to be very crucial in driving system change through leadership endorsement, which is where leaders, they're actively working to communicate what is integrated behavioral health, what is PCBH to their board members, and explaining why it's important to implement that model, supporting improvements in active manners. And so it has to be a very collaborative effort. It should be all in behavior, where after creating that integrated care commitment, right, committing to implementing PCBH, each model, each leader, they should have specific, measurable, achievable, relevant, and SMART goals to contribute to that ultimate goal of system integration. Apart from the leadership support, they should also assist in workforce development, things like IT, EHR decisions. That's going to be very, very important. Investment of resources like allocating dollars. You need to have funding in order to make changes. And so leadership is where this is where they can really be helpful in allocating dollars for that. And then focusing on the workflow, such as shifting staff to work in different capacities. Roles are going to change if you're going to implement this model for each of the team members. So workflow will also need to be prioritized, and this is where the leadership can also get involved and help with. Then next, we have the role of the patients and the family members. So here, the patient in the PCBH model, they need to be able to communicate their goals and their desires to, for improved health. And this is where the behavioral health consultants, they are going to play a very important role in creating that safe environment for patients so that they're able to discuss, what is going on with their health and discuss a plan together and come up with a treatment plan that works for the patient. So patients should be willing to participate in the evidence-based interventions that Alina just talked about, complete the screening assessments that are needed in order to fully understand the overall health of the patient, and also, follow up with the treatment plan and keep the teams informed about how they're doing with the under the treatment that they're currently going through. So that is the role of the patient in this model. Then next, we have the role of the primary care provider. And one of the most important role of the primary care provider in this model is to integrate a behavioral health provider into a routine daily practice and make sure that they are counted as a core member of the primary care team. They also are the ones to utilize the behavioral health consultant's skill where they seem fit in, into ongoing primary care management of patients. They work with behavioral health consultant to expand the impact of their service in the practice. They maintain real-time communication. They are receptive to the feedback from the behavioral health consultant. They make decisions collectively, and they work with the clinic staff and the team collaboratively to identify, develop, and implement changes that are essential for PCBH. And then next we have medical assistants and nurses. So the role of RN and medical assistant in this model includes identifying patients to refer to the behavioral health consultant. If they find that a patient has some kind of behavioral health concern, then they know to connect that patient to the behavioral health consultant. They're also the one to arrange and truly engage in facilitating the interaction between the patient and the behavioral health consultant, such as finding an exam room where the two can actually meet and discuss. And then they are also there to support and encourage patients' decisions to pursue behavioral health goals. And they're also there to address any issues that are related to the interface of the behavioral health with the nurses, MAs, and the primary care providers. And lastly, they also assist in maintaining patient workflow or resolve issues in maintaining patient workflow as they are related to the behavioral health consultant's involvement with the visit of the patients. So those are the responsibilities and roles of the nurses and the medical assistants. Next, I'm going to, oh, sorry, I have one more. So then lastly, we have admin assistant, and these are mainly your front office staff who are responsible for checking patients in, checking out, running insurance authorizations, collecting payments as needed, and the scheduling team, who are going to be more of a centralized team. They mostly operate online for all patients to call and schedule or reschedule their appointments across the whole clinic or the system. The nursing team are responsible for triaging, finding room for patients, identifying their reason for visits, and help coordinate referrals. However, all of the team members that I've mentioned beyond. So next, I'm going to pass it over to Alina to talk about the role of the behavioral health consultant.
All right, so the role of the behavioral health consultant, also we refer to them as BHCs. So every time, I think I've already said this a million times throughout the presentation, a BHC is a behavioral health consultant. They're important just like all the other team members, but they are also kind of the center point that kind of connects everybody together. So when you do integrated behavioral health, you cannot have a successful delivery without this role or this BHC individual, right? So let's start with their practicality of care. At a BHC, they manage the primary care patients alongside the PCP by identifying or addressing their medical or behavioral health concerns. They work with the PCP and patients to identify and treat the best treatment plan and triage to prioritize patients that are in need for a BHC consult. And I think this is also my favorite part, but it's also the most important part to describe the role of a BHC. And that is summed up in just one acronym, and it's GATHER. So each of these letters, they stand for something, and starting with G stands for being a generalist. And Sujina did mention this a couple of times. What that means is that they are to be assisting patients of any age and with any kind of biopsychosocial issues. A stands for accessible. So this is where they strive to intervene with all patients on the day they are referred to. T stands for team-based. This is where they share a clinic space and resources with the PCP, and they also assist the PCP's team, or well, at this point, it's all of their team in various ways. H stands for high volume, which means they engage with a large percentage of the clinic's population, just like the PCP. E stands for education, where they help improve the team's biopsychosocial assessment and intervention skills and processes. So remember, a BHC is the only mental health expert in the team, in the primary care team. So therefore, it's kind of like they're obligated to help the team increase in their knowledge with mental health and how to recognize certain certain things, right? And lastly, for the acronym, the last letter is R, which stands for the fact that it stands for routine, and that stands for they are a routine part of the biopsychosocial care. And now moving on to their philosophy of care, they believe that behavior can be learned and it can be maintained. So they educate patients about behavioral change and assist them in developing skills that are necessary to make those changes. Because sometimes, even though patients might know of the skills, they might struggle with knowing how to perform it because of either limited practice or inadequate feedback. Like my mom, she struggles with liver disease, and the doctor has told her a million times to have a no salt diet, but it's so hard to do that because my background, we're Indians, and I don't know, like, I don't think we know how to change our Indian food or the recipes for the Indian food to kind of make it in a way we don't add salt because it has so much spices. And so I think it's kind of hard for us to do that on our own. And I'm not saying a BHC is going to be perfect at that, but definitely when it comes to other skills and other practices, a BHC can be very helpful. And so that leads to say that behaviors can change, and it can be a powerful tool to improve health outcomes. And I think the biggest thing about behavioral health is that we don't really realize how much of an outsized influence it has on health outcomes, right? Like if mentally, I think Sujina and we were just talking about it yesterday. If mentally we're not feeling good, it kind of impacts our performance at work. It impacts how active we are in our personal life, how we feel about ourselves, and really just everything we do. And lastly, a BHC's focus of intervention is to create behavioral change plans that improve health by teaching skill sets that are vital for maintaining those behaviors that they can use to ultimately reach their health outcome goals. And like I mentioned earlier, they do this by educating and providing skill trainings to the patient. And it's not just a generic plan that they throw at the patient, right? They develop a specific behavioral change plan that's applicable to the patient's life and scenario. And that's kind of all that I have for the role of a BHC. And I think I saw a couple of you just ask if these slides will be shared because it is about to be one. It will be, but for those of you who are just staying back, I want to ask you, like, based on these descriptions, how many of you here represent a behavioral health consultant or a behavioral health provider? And how are you operating as a behavioral health provider at your clinic that is different from what we have said here? Because this can be all in theory, and when you actually come to practice in this role, it can be very different from just theory, right? So if anyone wants to speak up or just type in the chat if anything that we've said here, it resonates with you, or there's something that's different, we'd love to hear more about it.
I actually have a quick question that I don't know. I guess I'm still sort of so I'm a child psychiatrist and we're working to implement COCM, and I guess I'm just still like not totally sure of like what the workflow or like exactly what this looks like in practice. Like I understand kind of what we're saying the roles are, but could you give us like if I was the patient, like this is how I'd get to the BHC, or like how does this actually work? I don't know. I guess I still feel sort of like confused about exactly what this looks like in reality.
And I think honestly, we do have a training in a couple of weeks from today. I think 2 weeks. Victoria, Victoria will send you the date and details to register. And in that presentation, we're actually going to discuss workflows and how to get started, and really just like those realistic aspects on how to apply this. But for the one from 2 weeks from now, that's for the PCBH model. And so Victoria will also share one, since you're trying to implement the COCM one, we'll share details on that one as well, so that
Yeah, that's great. I think I understand the COCM one, and I'm just trying to
Mhm.
make sure that we kind of know what all the options are as we move forward. And so I think
Yeah.
just having not, just kind of exactly
No,
understanding.
yeah, that makes sense. Yeah, because this is all in theory, and when it actually comes to applying it, it's really complicated because every clinic is very different, and workflows can be really hard to, I think, move through and make sure it's smooth. And Sajina, did you want to take over from here?
Yeah, Selena, I hope I'm saying your name right. So you asked for an example to give you, just sort of walk you through how patient gets to the behavioral health consultant. So we've been echoing this all throughout the session today. Behavioral health consultant, they're part of the primary care team. So let's say a patient walks in and they do a screening and they realize that this patient shows some kind of behavioral health concerns. And so the primary care provider is the one to first see the patient, and they let them know that, hey, we've noticed that this is what has come up on your screening. We would really like you to see a behavioral health consultant who is actually here available if you're interested in seeing them. And if you're comfortable talking to them about what is going on, then we're happy to connect you to them. And so this is where having behavioral health provider on the spot is so important and so crucial, because that's where you can actually do the warm handoff and have patient wait, go get your behavioral health provider, debrief them on the patient's case, let them know what is going on, and ask if they're able to take over from there. And then the behavioral health provider will then walk with the primary care provider to the patient's room. The primary care provider introduces the behavioral health provider as the consultant, and that's when they take over, and then they do the brief interventions, which is basically motivational interviewing, having conversation with patients, and from there, then they get to the treatment plan. And that's how the workflow works. It's supposed to be a very quick 20 to 30-minute session with the behavioral health consultant, versus in a collaborative care model, it's a very systematic approach, right? You're working with patients who are already diagnosed with mental health illnesses, versus here, it's on a case by case, but not so much case by case for mental health, but it's for general health of the patient. Does that help you?
Yes, no, it does. So it's sort of like a trigger, either a PHQ-9 or something, or the primary care.
GAD-7. Yes, exactly.
Okay. And then my last kind of follow-up, I know you had said kind of 6 visits. Is that then the patient might schedule a follow-up appointment with the BHC separate from their primary care doctor to finish the follow-up, or would they only see them? Okay.
Yeah, the follow-up, after the first initial meeting, if there's a need for follow-up with the behavioral health consultant, then that's where the 1 to 6 sessions, that's how it takes place.
Okay, thank you.
Yeah. So do we have any behavioral health provider in the crowd? We would love to hear from you and really see what information that you heard today was surprising to you and how you're actually operating at your practice. It would just really help us to see how it actually plays out at the clinic.
Hello, everyone. I'm a behavioral health consultant. I've been a BHC for about 7 years now at a FQHC in the Philadelphia area. Everything totally lined up other than a mention around sessions. We're running into huge issues right now getting patients connected with specialty care. Whereas though in the past, we would be able to hold patients or see them short-term brief for maybe 1 to 6 sessions. Now we are certainly seeing patients more ongoing or more long-term because there's just nowhere to refer them to. So a lot of times we will refer to specialty care. Patient will do the intake. They will get discharged, and then they'll end up coming back to primary care. So it's been a little bit challenging navigating that. Ideally, it is short-term, targeted, brief care, but we certainly have been holding on to patients that probably should be in a higher level of care or more specialty treatment, but there's just no resources that's available, or the waiting lists are really, really long for outpatient behavioral health treatment. So we've been sort of, falling into those lines of therapy, which I know isn't necessarily the role, but we just don't have those resources available in our area right now.
Thank you for sharing. And can I ask you one more thing? You mentioned you're part of FQHC. So what's the ratio of behavioral health provider and primary care?
We have 2 behavioral health consultants to 4 to 5 primary care providers. We have mostly nurse practitioners, but it's mostly 2 to 4, 2 to 5.
Oh, that's good. Yeah, because the recommendation is that 1 behavioral health provider for 4 primary care providers. So that's a good ratio that you guys have. That means you're on demand for sure to have 2 behavioral health providers. Anybody else would like to share?
So Gina, some folks in the chat have shared what seems like echoing what Karima was saying, that there seems to be patients that end up needing like well beyond the 6 sessions.
Yeah. Jacob shared that Shelby have found the same to be true in regards to treatment being extended when there are few specialty mental health, behavioral health resources to refer out to. Okay, so now let's get to the activity. I'm gonna skip this part real quick. I'm just gonna put this actually as a placeholder for you all to look at. This is what we're gonna talk about on our next training. We're gonna focus on how to get started with the PCBH model in terms of implementing it. And there are 3 specific areas that you have to target when you're thinking about system change. And that includes the executive practice leadership, includes clinical delivery and financing and payments. Of course, no money, no mission. So we're also going to talk about that as well. But this is going to be, we're going to do a deeper dive on this at our next training. But before we end this session today, I did want to do a quick activity with you all. So open up your chat box. And I want you all to write down, with the information that you've received today, what would an optimal PCBH would look like for your clinic. Take about a minute to write down and put it in the chat box. Okay, Jennifer says, expanding our existing platform to encompass COCM while adding another behavioral health provider to our primary care team. Access, specialty, okay. It seems like it would be most ideal to have PCBH in addition to COCM and access specialty. Referral so that patient can be triaged to most mild, moderate, and severe. Multiple specialties, along with care coordination, develop referral network pathways to community and specialty mental health. These are very, very good. Next, what I'm going to do now is we're going to put you all in pair. Victoria, are you ready for the breakout rooms? And you're going to share your notes with your partner and combine your notes and come up with an ideal optimal PCBH that you would want to see at your clinic. And we're going to bring you back and have some discussion around that. And then we'll put you in groups of 4 and have you do the same thing again, share your notes and come up with one optimal PCBH that would look like at your practice. And then we'll come back and have discussion on that again. Okay. We're ready, Victoria? Okay, go ahead. Please join your breakout rooms. It should be popping on your screen right now.
I'm in room 10. Am I, or I'm going to room 1?
You're not.
Yeah, I was gonna ask, am I joining?
Has it been a minute? So many.
Yeah, we might have to, hold on.
Might just have to bring it back.
Okay. Are you bringing back?
Yeah.
Wait, I think we have enough. Room 3 only has 1 person.
Yeah, let me move to.
And there's, on room 9, there's 3. I feel like they're in the middle of a conversation and we're just gonna pull them out.
They're what?
No, I was saying in room 9 has 3 people and room 2 only.
Angelina just sent me a message saying she was in the room by herself.
Yeah, I've been trying to move folks because not everyone joined.
Oh.
Mm-hmm.
Is she moved now, Angelina Collins?
I think she left. Or no.
Still just says not joined.
Yeah.
I'm still here. I just left that break room, came
Sorry
back.
about
You
that.
guys know I was by myself, so.
I'll send you to room 4 with 2 folks that are in there.
Okay, thanks.
Sorry about that, yeah.
No problem.
Do you want to bring it back after this, Sujina?
Yeah.
Okay, so much longer? 1
Give them
minute?
some time. I don't think we can do 4 anymore because we don't have enough people. So
do it now?
no, give it another minute. Someone just joined not too long ago.
Hello.
Hi, Sherry.
Yes, I had to step away. I'm in the office to
No
go to
worries.
the restroom and I missed something. Were you trying to get people for a group?
Yes,
I didn't hear the question. I'm sorry.
no worries. Can we move her to one of the rooms, Victoria?
Room 7 and room 8 is
Or, yeah, 7 or 8 will work.
Oh, you need 7 or 8 more people?
Sherry.
No. We're
Oh,
putting you in a breakout room.
Okay.
There you go.
All right. Okay, breakout room 8. Okay.
Mhm.
Thank you.
Of course, thank you.
Can you send a message now saying 1 minute left?
Well, I can close rooms and it'll count down to 1 minute.
Oh, okay, then we can do that too.
I feel like these are providers who might have just had to step away because of a patient or something.
I mean, yeah, look at the numbers. Dipped. I just wanted to take a shot at it and see if this would be good.
I think we should just do it midway next time.
How did it go?
I just caught the very end of it.
I'm sorry.
That's okay. That's okay.
We're also trying to be mindful of the time. So, and I realize many of the participants have already left. So I don't think we'll be able to do the group of 4, but would anyone want to unmute and share with us how was that experience? What did you guys come up with?
Well, this is Angela. My experience was pretty brief, but what I did get, it was nice hearing from, I can't remember who I was with, but she was engaged in 2 of the programs. And it was nice to hear her experience and her challenges. I can't remember who that was. Hopefully she's on and can provide more detail with that, but or not. My experience was good. It's, this is new for me, so to have been put in a room with someone that's actually doing it and can identify some challenges was very helpful.
Good, I'm glad to hear that. Anybody else would want to share? How was their session?
I had a good session. I was with Sarah. I initially struggled with the question because so many different things come to mind. It's kind of hard to narrow it down to a couple things that may be optimal, but she shared about things that I totally agree with, just around having providers in the same space, in the same building, the medical providers and the behavioral health providers, so that way they're able to collaborate daily and consult often around patients. We talked a little bit about like huddles or morning debriefings, taking a look at the schedule, seeing who the patients are that's coming in that day, who needs behavioral health support, who may need to see the RN, who may need to see the care manager. And then we touched on supportive leadership, being able to get backings from those who are higher up within the company.
Yeah, I mean, we used to say that we need to get provider buy-in. I think our providers are bought in. It's the leadership that we have to go after. So I absolutely agree with that, Karima. Anybody else?
We had 3 people that are just learning in the learning phase. So we were just kind of, and coming from various backgrounds, but I think kind of just discuss that it seems like really from what we were seeing in the comments and things from others, that just having a spectrum of care, this being part of a spectrum of services that we can offer patients is sort of most ideal to make sure that, we can meet everyone's needs. And also if people have more complex illness to kind of get them where they need to go, as well as sort of figuring out how to allow people to practice at their top of their license and kind of care coordination and community resource navigation and how that all fits into.
Right. Thank you for sharing. Anybody else?
I'll share because I was the person in the room with Angelia that was talking.
Thanks, Shelby.
I'm in a federally qualified health center, and we have BHC and specialty, and we'll be launching COCM sometime in the near future. And I think one of the things that we're really struggling with is trying to have really kind of clear pathways around who is appropriate for what service and at what point do we make those kind of transitions. Because I think right now it's hard for some of our like support staff, like our patient access and scheduling, to support us in managing our patients and scheduling, because they can't tell like who's actually in BHC and can see anyone and who is actually like supposed to be assigned to like a particular clinician. And one of my struggles too is with COCM being so closely tied to an outcome measure. To me, it seems logical that less complex patients would go to COCM so that we could have very clear focus on depression or anxiety, and we would keep more complex in BHC, which is the opposite of what you had on the screen. So I'm wondering about that.
So that's interesting because what I've learned is the reverse, is that complex patients with, mental health diagnosis go to the collaborative care model. They fit better under the collaborative care model because, you need to take a more systematic approach. You need to have a registry in place to track the patient's improvement. There's just need to have a better system in place. Whereas PCBH, it's focused, it's a short-term care and it's focused on a general health of the population. But yeah, having a BHC and a specialty, that I understand that confusion very well, but I also think it all goes down to just knowing what your population, the population that you're serving, just knowing, what the need is and which model would fit better for that patient population that you're serving. Okay, I think, is there anybody else that want to share? If not, then you have all been so amazing today. Thank you so much for participating. And for those who have been in this journey of implementing collaborative care model, we have a training that's coming up on that in a couple of weeks. I'm actually gonna put up the upcoming, so next one is gonna be on the PCBH implementation piece. And after that, we're gonna talk about the codes. You all know financial aspect of the model, it's going to be very important. So we're going to talk about the PCBH codes and everything related to that, billing and reimbursement for that code, for that model on the week after May 17th is when we're going to do that. So if you're interested in signing up for that, please do so. But I've seen many folks here who are trying to implement COCM. So we really hope you will be able to join us for that training as well. Okay, if that is all, then thank you all so much for joining. We hope to see you all in 2 weeks. Take care, everybody.
Thank you both. Great presentation.
Thank you, Angela. Take care.
For all three.
Thank you.
Michelle